Good morning. It's our first episode in gastroschisis or gastroschisis, which is a very important topic for neonatal surgeons. And we'll start with our preferred book. Maybe in this series of gastroschisis, I will be discussing it from here and from clinical case studies and from Ashcraft. And a single paper that's very important for the updates of gastroschisis. It will take around 5 to 6 episodes in my calculation, but it may be more, maybe less, I don't know. Neonatal abdominal wall defects. We'll start with gastroschisis and omphalocele, but the main scope now is for gastroschisis. But actually, as an introduction, we'll start talking about gastroschisis, and the omphalocele are the most common congenital abdominal wall defects. They are more common than others, like canthal pentalogy, like the ectopia vasica, like the any other. Typically identified on prenatal ultrasound. It's typically identified. If it happens that it's not identified on prenatal ultrasound, that means that it's operator dependent and the operator missed it, and it's quite uncommon. 50 to 70% of infants with omphalocele have association, mainly the cardiac association. And this is a very important question in any board, that the cause of death and morbidity in the omphalocele is not the eviscerated bowel covered by the Wharton jelly, but the most important factor of criteria of morbidity and survival is the cardiac anomalies. If they are severe, even if you painted with betadine and waited until closure, after that maybe the patient will be lost due to cardiac anomalies, because they may be very severe. On the contrary, the gastroschisis is rarely associated with these anomalies. Have association with malformation that impacts the survival. It's more than 90% induced with isolated omphalocele, but less than that, pretty less than that in associations with cardiac anomalies. Semi-analogously, survival for simple gastroschisis is more than 95%, and they are mostly not associated with cardiac anomalies. But they may be associated with intestinal anomalies like atresia or closing gastroschisis or necrosis or severe edema or stenosis, and maybe it will lead to less survival and more mortality, up to 30%. Operative treatment of gastroschisis varies based on clinical circumstances. If it's it means that if it's spring-loaded silo or it's primary closure. Institutional resources and surgeon preference can include a variety of options for primary closure or a staged closure using silo. Bedside closure with a fold over of the umbilical cord stalk to cover can also be performed. Omphalocele are closed primarily when feasible. Otherwise, the sac can be allowed to epithelize with paint and weight approach. It's a very nice approach, and it leads to epithelialization until it's totally covered with skin, and this Wharton jelly is now not hazardous, and the closure after that of the muscles can be done at 1 or 2 or 3 or even maybe 4 years. So starting with the gastroschisis presentation, it's evisceration of the bowel, and they didn't return again, and the abdominal wall defect didn't close. Through a para-umbilical to the right of the umbilicus, full thickness defect in the abdominal wall means skin, subcutaneous, and muscles, and fascia, of course. To the right of the umbilicus, no overlying membrane, there is no cover. That means that the bowel is in contact with the amniotic fluid the whole time of pregnancy, and this will lead to severe thickening and edema, which is usually encountered in these cases. Pathophysiology. Failure of the closure. We do not know this failure is due to which cause and what are the causes of gastroschisis. but it results in a defect which through which the abdominal content can herniate. Actually, this is a normal physiological embryological step that they herniate outside, as we said, and they do the rotation and so on in order to leave room for the solid organs to grow. But since they didn't return to the abdominal cavity, there is something called loss of domain. Loss of domain means there is no room for this intestine again to get inside. That what makes it sometimes impossible to close it if the abdominal cavity is very narrow, and you should do staged closure. Loss of domain from absence of abdominal viscera within the peritoneum. The incidence is 2 to 5 per 10,000 live birth, and overall incidence worldwide in recent decades is increasing, associated with young maternal age and with low maternal body mass index and with nulliparity. Three things: nulliparity and young age and low body mass index of the mother. 1 year survival rate is from 90 to 95%. Actually, the 10 or 5% are allocated for the cases with severe complications in the intestine or the severe complications that are syndromatic. Cases that are syndromatic have comorbidities, and this is not common. Prenatal diagnosis: it's diagnosed on prenatal ultrasound at 12 weeks gestation. We can diagnose it with the prenatal ultrasound, and we take from the maternal serum alpha fetoprotein, it's elevated. And number 3, the criteria, the MRI, fetal MRI is not a routine step. The criteria is that the ultrasound of intra-abdominal intestinal distension greater than 95% sensitivity and negative predictive value. 95 sensitivity, but only 20 to 40 specificity. The presence of fetal bowel distension is not definitive diagnostic criteria, but if you exclude by prenatal ultrasound, it has an accuracy of 95%. Initial treatment: there is an initial treatment and operative approach. We'll take with us here in the initial treatment, which is actually more complex than the surgical approach. The surgical approach is very simple. It's either one of two ways: closure in one stage or staged closure with the silo, and we'll go through it in the second episode of gastroschisis. But here the delivery concerns, it's not a must to make it a vaginal delivery, cesarean delivery, but the rule is to be a vaginal delivery. It's not a must to be a preterm labor, but the rule is to have a vaginal term or full term labor. Some authors advocated this 36 weeks gestation to allow for removing the amniotic fluid from around the bowel, but this is not evidence based. There is no evidence to support, and similarly no evidence to support the early delivery for purpose of abdominal defect closure. Nothing precludes the vaginal delivery. Term vaginal delivery should be the goal for most of the neonates, and here there are two concerns: to be term and to be vaginal. Cesarean delivery only is done for some special cases. Immediate treatment with nasogastric decompression is a basic, and commencement of fluids is one of the basics, which is isotonic fluid, 10 milligram per kg. If he is 3 kilograms, he will take 30. It's like the shock therapy, and then maintenance after that. And do not over resuscitate in order to avoid the third space loss and the edema of the bowel. Inspect the bowel for ischemia, for perforation, for stenosis, for closing gastroschisis, and identify of any atretic or cyanotic segment. It's a must that the surgeon inspects everything before the operation. Conversely, the inflammation can create appearance of an atresia or stenosis where none exists. Okay. When primary closure is not possible, you will use a silastic spring-loaded silo or staged closure. TPN is a must. Commencement of IV antibiotics is a must, and putting a PICC line or a central line is a must. This is an introduction for the gastroschisis. The gastroschisis will have many episodes with us here because it's a quite subspecialty and neonatal surgery. Second time we'll start the operative repair and the post-operative. Every single step in the gastroschisis, either prenatal or preoperative or operative or post-operative, is crucial for a pediatric surgeon to know, and it's one of the basic surgical procedures in the pediatric surgeon's career. Thank you and see you next time.